So I'm John Miner from Spark, and we will go over a foot and ankle examination next. Here's my patient who presumably does not have an acute injury. Otherwise, a lot of this physical exam will be altered by what the patient cannot do secondary to pain from a most recent injury. But as much as I can, I try to start with functional inspection, having my patient stand, feet about hips width apart, just looking at foot and ankle alignment there. Maybe a teeny tiny bit of midfoot pronation, but otherwise she has good arches. The alignment is good. We don't see any swelling even as we're inspecting the ankle in this position. And we also like to be able to compare to the contralateral side. Now go ahead and have a seat up on the bed here. One more time, I like to inspect the feet and ankles together, inspecting both medially and then also laterally. Most ankle sprains are going to be lateral ankle sprains, so making sure that you actually do compare the lateral aspects of the ankle for any soft tissue swelling that can appear anywhere all the way around that lateral malleolus. Ecchymosis or any evidence of bruising can also tell you about any recent injuries or sprains, and many times blood and swelling is gravity dependent, so you will oftentimes notice swelling even down into the outside of the foot here. As we begin our palpation, it's important to remember that the talus, the dome-shaped bone in the middle of the ankle that rocks back and forth with dorsiflexion and plantar flexion, is trapped in between the medial and lateral malleoli, and the lateral malleolus belongs to the fibula. It's important to test for a syndesmotic injury as we begin palpation by actually palpating and manipulating that fibular head, putting some anterior-posterior distraction on it to see if that causes any transition or translation of pain down into the ankle. You can also test the syndesmotic joint with a squeeze test by squeezing the tibia and fibula together and then quickly letting it go and seeing if the patient seems to have significant discomfort as you quickly release. And you can also perform a lateral compression test on the medial and lateral malleoli using your palms and just gently compressing and squeezing those together to see if there's a very soft sensation of instability that becomes more stable as you compress, and you can compare to the opposite side. Then I like to actually press on the actual bony landmarks. So knowing ligament structures, the anterior talofibular ligament will go from the fibula over to the talus right in this area. So we'll press right through the anterior aspect, palpating for any pain with a grade 1 sprain. This is the one that is most commonly sprained, so expect your patient to have some pain if this is an ankle sprain. Your calcaneofibular ligament runs slightly anterior from the styloid process on the fibula down into the calcaneus, and that would elicit pain. It's difficult to get into the PTFL or the posterior talofibular ligament, but really back into the fossa or depression in the back of the ankle, you can press back there. It would be a much more severe injury if they have sprained that. In that location, you're also palpating through the peroneal tendons, which you can actually feel a little bit more superficially. And many times when a patient has sprained their ankle, they were attempting to stabilize the ankle and prevent the sprain by activating the peroneals. So it's very common to have peroneal tendinitis secondary to an ankle sprain. And you can palpate back posteriorly to the lateral malleolus. And then the peroneus brevis is going to attach into the base of the fifth metatarsal. So make sure that you palpate there, because some people will actually have a fracture and a avulsion fracture, and they may actually have a fracture through that base of the fifth metatarsal. The peroneus longus actually is split by this peroneal tubercle on the calcaneus. So the peroneus longus, there's a little bony bump right here. The peroneus longus goes inferior to that and will actually run across the bottom of the foot and attach into the base of the first metatarsal more medially. Other places that you want to press while we're still lateral are small joints like the sinus tarsi, which is a small joint where a fat pad also exists between the calcaneus and the talus, and you'll feel a small depression or soft spot right through there. And a lot of times I see patients who have chronic pain right in that area months after spraining their ankle. Other places to palpate while we're still addressing mostly lateral aspect are deep into the back of the ankle, the posterior ankle fossa. Occasionally, even with an inversion ankle sprain, patients can patients can fracture the posterior talar process, and that can contribute to posterior ankle impingement. So seeing if they have pain there. And while you're at it, go ahead and palpate the Achilles tendon and through the heel. We see our 8, 10, sometimes as old as 12-year-olds with heel pain, with standing, running, and jumping, and they may have calcaneal apophysitis, also known as Sever's, and performing a squeeze test through that growth plate or apophysis on the posterior aspect of the calcaneus will also elicit pain in those cases of Sever's calcaneal apophysitis. I like to then move anteriorly across the anterior ankle joint line, seeing if that seems to elicit any pain. You're also palpating through extensor tendons across the front of the ankle there. Don't forget all of your bony landmarks, including the lateral malleolus and the growth plate that usually is a good 1.5 centimeters, 2 centimeters up from the styloid process on the fibula in your adolescent patients. And even medially, you'll actually get the physis of the distal tibia anywhere up to about 1 centimeter proximal from the joint line. You have other structures medially, ligament structures like the deltoid and spring ligament, palpating just distal to the medial malleolus and down into the inner aspect of the foot. Other bony landmarks that are important are places like the navicular bone. We occasionally see people with an accessory navicular, so this bone is very prominent and sticks out, and many times they were born with an extra bone. Posterior tibialis attaches into that bone, and many times these patients will have pain because of the tendon or because that bone is actually coming close to contacting the ground with running and walking. So that can be a common source of pain. And you can palpate through the flexor digitorum longus and flexor hallucis longus tendons that are both traveling in that posterior medial ankle as well.